So hi everyone, I'm an attorney at the Center for Health Law and Policy Innovation of Harvard Law School. We also go by CHILPI for short, and I'm really excited to be here chatting with you guys about this topic of social risk information as sensitive information. What are our privacy considerations? So my work really rests at the intersection of more traditional healthcare, regulatory regimes, and social care programming. And so we do a lot of advocacy for screening uptake and policies, like big P policies, governmental policies that really increase and incentivize and promote screening. And as part of that, we find ourselves at many tables where folks are wondering about privacy and disclosure concerns, right? We read in a lot of the existing research that both providers and community members themselves have fears about sharing their information and potential third-party disclosures. And we found ourselves asking, is there a there, right? How does the law really permit or protect against unsafe and otherwise unwanted disclosures of this social screening information? And then in the event that we identified vulnerabilities, we also wanted to be able to answer, what then, right? Because probably many of us in the room would agree or would hope that the response to that isn't that we do away with screening, but that there are small p, sort of institutional and organizational strategies, or big P, governmental policy strategies, to minimize those harms, right? So we also set out to understand what are those interventions, what could they look like? And then we set out to create an educational or informational tool that really lays out some of these practical strategies that we've been learning about. I saw someone in their presentation yesterday had like a QR code, and I was so jealous. And I couldn't figure out how to do it, but it's brilliant. But if you access the slides, I did make a hyperlink. So in terms of our methods, so we started with a lot of desk research, right, our legal research. We focused specifically on federal information privacy and information blocking or information sharing rules. We did not look at state law. That is a limiting factor. We also conducted a number of interviews with folks at this intersection of healthcare and social care, at large and small health centers, and then we tried to focus in on some of the populations that we were especially concerned about, that we had some hypothesis that there may be an exacerbated vulnerability here. And so that was with folks experiencing domestic violence, children or pediatric care, and then also working with older adults. And then we re-engaged this very brilliant group of stakeholders to review the recommendations that we really were hearing and echoing back, and then to offer sort of some additional targeted resources and tips from their experiences. So we effectively were able to crowdsource 3 key hypotheticals for our legal analysis, 3 issues that in many of our interviews folks raised up, that this has come up for them, this was a concern for them, and they wanted to know, is there that there? So we have a parent is concerned that sharing social risk information will put their family at higher risk for investigation or other intervention by Child Protective Services, right? Thinking about that conflation of poverty and neglect. Our second scenario is that a clinic that works with survivors of domestic violence is concerned that housing instability, other social risk information will be weaponized against a patient experiencing domestic violence in a custody dispute, right? So if I say that I'm housing insecure, is that going to make me an unfit parent in a custody dispute, and the person who is abusing me is able to really leverage that or weaponize that against me? And then the third hypothetical that folks raised up for us is that a physician is concerned about documenting disclosures of interpersonal violence where others, especially the perpetrator of violence, might be able to access that record or see that record. What we found is that the answer to each of those hypotheticals was really yes. Like, these scenarios are very possible. We have privacy protections, we have privacy law, we have rules, but privacy law allows for reporting to Child Protective Services, right? Privacy law allows for information to make its way into a custody dispute. Privacy law allows really for, folks to access our records and to see our records, especially in a situation where maybe I don't have control whether I share my password to my EHR. So we really found that when we're thinking about, is there a mechanism, right, for this information to be disclosed, the answer was resoundingly yes. And I'm happy to chat more about those mechanisms, but I really want to make sure we have time to talk about the so what. And so our idea is that by building a health-related social needs screening program that really considers these disclosure risks and potential harms, then healthcare organizations can really better position their program to minimize those risks of harm. Our research identified that strategies for risk mitigation really exist across the spectrum of activities, or sort of the logic model that I've heard many folks talking about in their screening programs over the past couple of days, right? So if we're thinking about, our kind of design and pre-implementation phase, there's lots of opportunities for us to ask, in my population, what are the greatest risks? And what does that mean for me, right? How do I think about implementing policies and procedures that might limit that risk based on what my population is concerned about? When we think about implementation, we have before screening and following a positive screen. So that means opportunities like informed consent and discussing documentation with patients. And on the flip side, a lot came about around limited or coded documentation, right? What do we say in our record? Can we offer services and supports that when we're saying, yes, there is a need, but look, we're also responding to that need, that changes some of these opportunities for harm. And then the engagement of social workers that, think about, well, yes, I hear you, I understand why you want to engage Child Protective Services, but are we going to get the outcome that you're looking for, right? Is that actually going to help this family? Or is it not something that we need to be leveling up to this way? And then we also had some folks who were doing really interesting things around evaluation, where they're actually monitoring for these harms. They actually are looking at their data and saying, is there an uptick, in reporting to CPS as we're doing this kind of screening in our pediatric population, right? And then, of course, applying our learnings if we do find any increase in harms. That's all kind of high level. So, there we go. So for each of these kind of phases of the screening program, we go deeper. We really were able to do that crowdsourcing again of what are helpful resources out there for each of the kinds of interventions that we're talking about, and bringing out tips from the experts in the field who are really doing these interventions, who are really learning from these interventions as to what might we all be able to implement or think about in our programs and get to this better place, right? So that's kind of small, but a lot of it in this kind of pre-implementation phase, thinking about appropriate policies and procedures, right? A lot of it is about how the policies and procedures that we have around communicating with our patients around screening, the trainings we do for our providers around screening, and how they communicate with the patients about risks. And really, a lot of informed consent came even into here, right? That we're building informed consent as a process into our screening program. So those are really the small p organizational policy considerations. But we also have several big P policy considerations, right? We identified 3 core strategies. The first is this idea that When advancing requirements or incentives to drive social risk factor screening in healthcare settings, we really want policymakers to be considering whether the design of the policy introduces the potential for harm. So do we need a mandate in this policy? What are we asking our healthcare providers to do? Are we giving them the flexibility, right? So one example here is that a state decided that they wanted their mental health organizations to screen for health-related social needs as part of their kind of quality metrics. So this became effectively a mandate for screening. And the screening tool that they had to use didn't include interpersonal violence. And the domestic violence clinics that we talked to really talked about, well, we see what they were going for, but they've actually really exacerbated the risk for our patient population. Because we're putting into the record something like housing instability, which the perpetrator could use against them, but we're not putting into the record interpersonal violence, right? Which would help battle against that and help us really create the cases we're trying to navigate. So that's an example of really thinking about, from a big P policy perspective, what are the harms and how does that impact how we shape our policy? The second example is that policymakers should take advantage of the growing array of tools at their disposal to really say, yes, we've identified a need, and we can connect patients with solutions, right? So something like Medicaid 1115 waivers, which create these opportunities to have responsive benefits. Well, when I'm concerned about reporting a family to Child Protective Services because they've come in through my ER and they're housing insecure, if my alternative to that is that I can actually send them for a housing support, then we're identifying the need, but we're also mitigating the issue that is creating the unsafe disclosure. So really encouraging policymakers to continue to lean into a lot of these opportunities. And then the third was really specific in particular to this issue of Child Protective Services, which is that, you know, mandatory reporting obligations should and can advance this distinction between poverty and neglect. So we had this great example from our folks in Massachusetts, which is that they actually have a really explicit policy on the books that says poverty or homelessness are not per se indicative of child abuse and neglect, and the child should never be removed from their parents and placed into substitute care on the sole basis of homelessness of a family. And so that's been something that healthcare providers and teams who are interested in minimizing this risk of harm in Massachusetts are really able to build into their programs. They're able to create these brighter red lines. And so having these kinds of policies on the books can really help ensure that we're navigating that distinction. And then of course, like the disparities in like who gets reported, right? And who is experiencing this harm. I will stop there, but I'm happy to answer any questions and keep this conversation going. And yeah, thank you so much.